Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan. Yang saya hormati Dr. Aswan Hakmi Lubis, spesialis anak MK selaku Direktur dari National Hospital. Kemudian yang saya hormati Dr. Irwan Barlian yang belum sempat hadir, nanti akan join dengan kita pada sore hari nanti. Kemudian yang saya hormati Dr. Bayu, Dr. Andreas Aryo Bayu, spesialis radiologi, konsultan radiologi intervensif. Kemudian yang saya hormati Dr. Ue-Cheung Ho from National Taiwan University Hospital, Yunlin branch. Yang saya hormati juga Dr. and staff from National Taiwan University Hospital Yunlin branch. Welcome to our hospital, National Hospital. Yang saya hormati teman-teman para media dan juga peserta, dan juga teman-teman dari Alliance. Pada sore hari ini, National Hospital bekerja sama dengan National Taiwan University Hospital Yunlin Branch mengadakan case sharing dan discussion mengenai advance in brain tumor and aneurysm management. Jadi pada sore hari ini kita semua akan mendengarkan case sharing dan diskusi dari pakar-pakarnya. Nanti pada akhir sesi kita akan buka sesi tanya jawab juga. Jadi untuk teman-teman peserta dari Alias, dari para media yang ingin bertanya nanti setelah sesi terakhir. Sebelum kita memulai acara kita mendengarkan sepatah dua patah kata dari Direktur National Hospital kepada Dr. Aswan Hakmi Lubis, spesialis anak MKes. Waktu dan tempat kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon for all my friend, especially to Prof and the team, teman-teman Alliance, teman-teman media, Dr. Bayu, seluruh yang hadir. Prof, welcome to National Hospital. You can had to visit the hospital. Oh, maybe you can give the what suggestion for my hospital about the services or another. National Hospital, we have 200 bed. Then we give the services to all the diagnosis patient. Yeah. And then we have a center of excellence in National Hospital is the neurosurgeon. And then what we call it, stroke center and robotic rehabilitation, and then about the what we call it, aesthetic. Maybe we can learn in Taiwan, aesthetic. Yeah, we have National Hospital DAP. DAP is dermatitis, aesthetic, and plastic. As you know that the Surabaya people will go to Korea. Maybe in Taiwan is very good aesthetic, I think. Teman-teman media, kita pada siang hari ini akan mendengarkan bersama-sama tentang discuss about the advancement management on brain tumor and aneurysma management. Ya, jadi penanganan tumor-tumor di otak dan aneurisma. Ya, aneurisma adalah pelebaran pembuluh darah atau kelemahan dari pembuluh darah. Saya kira saya hanya ingin menyampaikan bahwa National Hospital will be joined to National Taiwan University. The future will be joined about the services, about maybe the neurosurgeon and another. Thank you for your coming to National Hospital. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih banyak pada Dr. Aswan. Kemudian kita akan lanjut ke acara berikutnya. Sebelum itu, perkenalkan saya sebagai moderator pada sore hari ini. Saya Dr. Karina Aprilia Wijaya yang akan menjadi moderator pada acara kita hari ini. Dan sebelum itu, perkenalkan saya menyapa dulu yang terhormat Pak Rivian. Selamat sore Pak Manajer kami. Kemudian, tidak berlama-lama kami akan masuk pada case discussion yang pertama. Sebelum itu, first of all, I want to introduce myself as moderator here. I'm Dr. Karina Aprilia Wijaya and will be a moderator for our case discussion for this afternoon. So maybe first of all, I want to welcome our first presentation from Dr. Ue-Cheung, neurosurgeon from National Taiwan University Hospital, Yunlin branch, will be discussed about the evolution of intracranial aneurysm treatments and future direction. Please welcome Dr. Ue-Cheung.
Okay, thanks for introduction. Okay, good afternoon. I'm sorry. I'm He Yu-Zhang, a neurosurgeon in National Taiwan University Hospital, Yunlin branch. And thanks for having me to come here to have the opportunity to share our experience and have the opportunity to discuss the evolution and treatment of aneurysm with you all. We know that the treatment of aneurysm has rapidly evolved in the past decade, and maybe the treatment might vary between region to region or even hospital to hospital. So hopefully we can learn some treatment strategy from you and can have some discussion after the session. This photo was taken by 2010, about 30 years ago, and I'm really getting older. And this is my first trip to be in Indonesia, and we went to the Bali for our graduation trip. The weather is good, and the people here is really very friendly. I really had a good memory at that time, especially Indonesia food like satay, ikan bakar, and ayam garing. I'm afraid of spicy food. I'm not sure that whether this food should be spicy or not, but I tried it. It was spicy, but the flavor is good, so I really enjoy it. So before going into the discussion of the treatment aneurysm, we have to divide in this kind of pathology into two parts. The one is a rupture aneurysm, and the other is unruptured aneurysm. Rupture aneurysm usually comes into the subarachnoid hemorrhage, and it is a very emergency situation that needs immediate surgical intervention. So when regarding the treatment of rupture aneurysm, we have two modalities to be considered. One is open surgery, and the other is endovascular intervention. But some people may come here just for examine their incidental finding of rupture aneurysm. Maybe they just for health examination checkup, or just do the brain MRI for non-specific symptoms like headache, dizziness, or etc. And they may be worried about how to treat a rupture aneurysm at that time. So when visiting this patient, we have the problem to decide whether to have the patient have such treatment. Because if we do the management or we proceed the patient to further management for the unruptured aneurysm, basically, the treatment for unruptured aneurysm is a prophylactic procedure per se. So the patient may be at risk of the complication from either two modality. But if we choose observation for this unruptured aneurysm, the patient may be at risk of future bleeding. So many factors should be considered in treating such kind of aneurysm. So let's proceed to the ruptured aneurysm at first. The ruptured aneurysm is a devastating neurological injury. About 40% of patients have this kind of disease, maybe have permanent neurological injury. Okay, thank you. Thank you. Okay, thank you. Maybe the system is frightened by such kind of devastating disease. Okay, so it's a devastating neurological injury, just as I mentioned that about 40% of patients experiencing this kind of disease may have permanent neurological injury. About 30% of patients may have good recovery after management, but there's only remaining 20% of patients may be died upon arrival to our hospital or during the hospitalization. So for neurosurgeon, it's very important to do the primary intervention for secure the aneurysm to prevent the aneurysm rebleeding, because the rebleeding is one of the most leading cause of mortality and morbidity about this disease. And just like other acute brain injury, the patient suffer from this kind of injury may experience secondary injury after the insult. So for most of us, we have to do the secondary intervention to prevent or treat the secondary brain injury, especially delayed cerebral ischemia in this setting. So when I was a resident, many professors told us that if the patient's neurological status is poor and the SAH grading is poor, then we had better to keep the observation and not to do the management. But because recently more data reveal that such kind of patient may benefit from more aggressive management, even they are very poor grade upon arrival to our emergency department. So in our clinical practice, we will have the comprehensive discussion with the family, and if they can understand the natural course of the disease and the problem they might be face, then we will do the operation for them. And about the timing of the operation, we will do the operation as soon as possible because of the risk of rebleeding. And if we postpone the operation, the brain may swell and will make the operation more difficult. So if the patient is very fragile or have multiple comorbidities, or their neurological, premorbid neurological status is poor, then maybe we can introduce palliative care. But if the family still hesitates at this emergent situation, then we will proceed to the management immediately. Then maybe we wait for their recovery and introduce palliative care or other management if clinically indicated. So regarding the medical management, the blood pressure control is a major issue. Although no systemic data that address the optimal blood pressure when managing this patient, but we often keep the patient's systolic blood pressure below 160 millimeter mercury. And this measure is safe and is not associated with rebleeding. And about the antifibrinolytic therapy, more researchers have found that there's no benefit on functional outcome or mortality. And in terms of delayed cerebral ischemia and shunt placement, and the result is comparable. About the seizure, if the patient had seizure upon arrival, then the patient may be at high risk of future seizures, so anti-epileptic agents is definitely needed. But if the patient did not have the seizure upon arrival, then the prophylactic use is controversial because we don't know whether the prophylactic use is associated with neurological outcome. Although the previous study revealed that the long-term use of phenytoin is associated with poor outcome, but as we know, the phenytoin is a really old drug, and in the current market, we often use the levetiracetam and valproic acid or lacosamide for the seizure prophylaxis, but there is not so much data regarding its use. But indeed, short-term use of AED can decrease the risk of short-term seizures. So in our clinical practice, we will use a short course of AED prophylaxis for fear of the patient might have seizure during the operation or during the hospitalization. So the most important part is that when we decided to let the patient proceed to the surgery, then or the management, so which one is more suitable for this kind of patient? And as a neurosurgeon, we are very familiar with these two kind of trial. One is AT and the BRAT. They have very long-term follow-up to see the effect of the coil or the clipping. And in a neurosurgical perspective, many neurosurgeons will advocate or try to persuade the patient to undergo the open surgery because we think that the neurological outcome is good. But the fact is not just at this kind of data. Currently, the long-term follow-up to see the effect of these two trials did not make a very consistent data. But we know that there are so many limitations regarding these two trials because the recruit population exists selection bias, and the follow-up time is different, and more importantly, the intervention group, all of them are used the simple coil only. But with the advancement of the technology of endovascular intervention, there are so many kind of other equipment to treat this disease, such as stent, acetylene coiling, or flow diverter. So the comparison between the coil and the clipping should be examined. But let us try to see these kind of things from other perspective. Why should we always compare the operation to the endovascular therapy? Both of them have their advantage and their weak point. So maybe they can be the complement to each other rather than the competitor. So I think the hybrid technique is the future trend for the treatment of the aneurysm, especially for a complex aneurysm or the initial treatment of the aneurysm is not satisfied. Here's the list of the operation and the endovascular intervention just listed below. And I think the new technology is just like the pendulum. It swings back and forth during the time. When the new technology had invented, we often feel this technology as a very new tool and it can solve any problem. But when we use it more and more, we will find some limitation, just like the pendulum swing back a little bit. Then when it was in a stabilized situation, then maybe we will find the most appropriate indication or contraindication of such technique. So this is the same philosophy for the treatment of other disease. So here is our hospital's algorithm for treatment of rupture aneurysm. If we found the patient had aneurysm, regardless of the anterior circulation or posterior circulation, then we will check the CT or CTA to see if there is other vascular lesion or the space-occupied hematoma or obstructive hydrocephalus that necessitates immediate surgical intervention. And then we will discuss with our neurosurgeon whether the surgical clipping is feasible. If both answer is yes, then we proceed to the surgery because we can deal with the aneurysm secure and that threatening pathology at the same time. But if the surgical clipping is not feasible, for example, it's a posterior circulation or the base area artery tip or I-cup aneurysm, then we will do the surgery. But we do the surgery just for the CSF diversion or do the hematoma evacuation. And after the operation, we will consult radiologists to perform endovascular intervention to do the aneurysm secure. But if the patient did not have such kind of condition that need immediate surgical intervention, then we will consult the radiologist immediately to see if the coiling or the other intervention is feasible. If the answer is yes, then we do this. If the answer is no, then we will perform the surgery. So that's a brief introduction of our hospital's treatment algorithm for the cerebral aneurysm, ruptured cerebral aneurysm. And this is the first thing. But the second thing, just as I mentioned, this patient survived the first timing of aneurysm secured, but the patient may experience a secondary brain injury because it is the major cause of the delayed neurological deterioration to this patient. So for the most part, the patient had a delayed cerebral ischemia. In the past decade, we often found or often think that the patient have neurological deterioration just because of vasospasm. But we now know that the vasospasm is not equal to the delayed cerebral ischemia. Because delayed cerebral ischemia developed in less than half of patients with angiographic vasospasm. On the other hand, DZI does not occur consistently in territory vasospasm. Maybe the patient had a new onset of weakness in the right side, and we do the perfusion CT scan, and it showed the poor perfusion on the right side. So we know that that is not the same thing. So we maybe not to have to proceed the management to treat the perfusion, decrease perfusion to the right side. But maybe we can take other measures to improve this neurological outcome. And also, asymptomatic DCI is associated with poor outcome. So in every measure, we have to do something to prevent or to treat the delayed cerebral ischemia. So this is an article published in 2021 and 21st, and it's summary the all kind of pathophysiology that may be involved in the development of delayed cerebral ischemia. The rupture aneurysm has sent the blood into the blood compartment, majorly in the subarachnoid space. And the degradation of product of this kind of hematoma will cause the local ischemia or change the electrical property of the neuron and it cause cortical spreading depolarization. And it may elicit the inflammatory cascade to break down the BBB. And further, the coagulation and the thrombosis system may be imbalanced. So the patient may have microthrombosis and vasoconstriction. So according to this kind of pathology, the patient may have neural inflammation, perfusion mismatch, vasospasm, and microthrombosis, etc. So based on this figure, we can know that there are so many ongoing trials and the researchers had conducted to see the genetic background or the molecular pathway of this kind of pathophysiology. And maybe we can learn something from this to find more drug or other intervention to prevent such kind of neurological impairment. So in the past decade, there are some kind of research to see whether there is the substance or medication that can prevent the development of delayed cerebral ischemia, such like magnesium. Maybe it had a potential property to have a vasodilatation. And another is endothelial receptor inhibitor. And there are so many randomized control trials published in the very famous journal, and also the meta-analysis to see their results with different kind of dosage and a different kind of modality. But all of them did not have any conclusive results. And statin is a drug for lipid-lowering agent, and we also know that this medication had anti-inflammatory properties. So also there are reports to see the effect of statin, whether this can prevent the delayed cerebral ischemia according to the STATCH trial and other several retrospective studies, including in the meta-analysis, but the result is also inconclusive. But this is the value of the surgery. The reports have found that if we do the clot removal or lumbar drain during and after the operation, we may prevent the development of delayed cerebral ischemia. It was reported by the LUMAS trial and several kind of meta-analysis. And if we do the clot removal, then the patient may have significantly fewer DCI and had a better early functional outcome. Although this kind of measure do not affect the long-term functional outcome, but during this procedure, the complication rate is low. So in our clinical practice, we routinely do this kind of measure. So here is our summary of our hospital to treat the rupture aneurysm. If we proceed the patient to the operation, then we will open the decreased membrane and the lamina terminalis at the end of the surgery to let the patient had more CSF flow. And at the day 4 of surgery, then we will do the perfusion CT. If there is no evidence of radiological evidence of obstructive hydrocephalus or other factors that may be considered to be contraindication to lumbar puncture, then we will insert a lumbar drain. The reason for this measure is also to improve the CSF circulation, try to reduce the burden of blood degrading products. How about if the patient had delayed cerebral ischemia? It just happened. Previously, we had known that we can do the triple H therapy to rescue the patient. Triple H therapy including induced hypertension and hemodilution and hypovolemia. But according to the recent research, only induced hypertension seems useful in increasing cerebral blood flow. But here is the caveat in this research. Many research during this experience or during this research, they try to increase the blood pressure in the treatment group more than 200 millimeter mercury. But when we see in more detail, in more methodology more detail, the control group, the author will still have the control group to keep the mean arterial pressure more than 85 millimeter mercury. So according to this concept, they may have some intervention to prevent the patient from the poor perfusion. Even we want to do the induced hypertension to this patient. So in our clinical practice, if the patient had delayed cerebral ischemia, we will not do the induced hypertension to make the patient's blood pressure more than 200 millimeter mercury, but we will try to use the fluid supplements or the other medication to keep the patient's mean arterial blood pressure more than 85 millimeter mercury, at least for 1 week, to reduce the effect of the cerebral ischemia. And if the territory of vasospasm is compatible to the clinical symptom of delayed cerebral ischemia, we will consult radiologists for the transluminal balloon angioplastic or intra-arterial vasodilator infusion therapy, such as nimodipine or verapamil. So let's go back to this figure. Then we know that if we know more detail in the pathophysiology of such kind of mechanism, then maybe more patient, we may prevent more patients from further neurological deterioration after the rupture aneurysm. Regarding the unruptured aneurysm, I use only 2 slides to share our thinking. Because we think that there's so many uncertainty in management of this patient. And more importantly, due to this reason, so we have to have a comprehensive explanation to the patient and the family. We know that definitely the aneurysm's location, its size, morphology, evolution, and the post-contrast image characteristic may predict the future risk of the aneurysm, but it is not the definitely factor. And according to the research, there are so many kinds of scores that predict the risk of having or not having the management of unruptured aneurysm. But none of this is practical because I think that to complete this kind of score, it takes really longer time. And I will fill this score as a concept to analysis the possible factor that may affect the risk of treating or not treating aneurysm. So it needs a comprehensive evaluation and explanation to the family. So here are the conclusion. The evolution of intracranial aneurysm treatment keeps continuous change in treatment approaches. And future research should be conducted to explore the molecular pathway underlying this kind of secondary brain injury. Maybe we can find more medication to rescue this kind of patient. And indeed, with the advancement of the endovascular technique, we have the preference toward the endovascular treatment because the risk compared to the open surgery is relatively low. Although there is some issue about the durability of this kind of intervention, but yeah, really its complication is low, and just as I mentioned, I think surgery and the intravascular intervention could be complement to each other. So if the patient after the primary management is not satisfied, then we can do another measure to treat this kind of patient. And here's the discussion. Thank you.
Thank you, Dr. Ue-Cheung, for the wonderful presentations. You may proceed because the question will be later after the presentation. Okay. Now we move to our second presentation from Dr. Andreas Aryo Bayu Seto, specialist radiology, consultant radiology intervention. He is a radiologist and radio intervention consultant. So please welcome Dr. Bayu will be presented about the role of DSA in intracranial tumor.
Thank you, terima kasih. Oh, yeah. Oke. Sore hari ini saya hendak menyampaikan, I'm sorry, I would like to do the presentation both in English and in Indonesia because I know the target market, the target audience is both speaks Indonesian and also English. Saya akan menyampaikan presentasi dalam bahasa Indonesia dan bahasa Inggris dengan harapan supaya menjembatani adanya perbedaan bahasa. Saya hendak membahas mengenai peran DSA pada tumor intrakranial. I would like to discuss about the role of digital subtraction angiography in intracranial tumors. Okay. What is DSA, digital subtraction angiography, or in bahasa Indonesia, angiografi substraksi digital. Sebelumnya saya hendak mengutip kata-kata penulis science fiction favorit saya, Arthur C. Clarke. Dia bilang begini, any sufficiently advanced technology is indistinguishable from magic. Nah, itu semua teknologi yang cukup tinggi itu tidak dapat dibedakan dengan magic, dengan sihir. Nah, jadi gunanya saya di sini adalah I would like to be a bridge. Saya ingin menjembatani perbedaan persepsi supaya nanti kita bisa tahu apa sih itu DSA. Karena kan kita sering mendengarkan, we often hear about DSA. What is DSA? Apa itu DSA? Hari ini kita akan mencoba menjelaskan. Pada prinsipnya DSA adalah teknik citraan medis untuk Angiografi itu apa dulu? Kita beda, kita pisah-pisahkan berdasarkan kata yang membentuk DSA itu tadi. Angiografi atau angiography itu teknik pencitraan medis untuk visualisasi bagian dalam pembuluh darah. What is angiography? It is a imaging technique to visualize the inside of a vascular system. Menggunakan sinar X, uses X-ray dan media kontras yang dimasukkan dalam pembuluh darah menggunakan kateter. We use X-ray and contrast media that is put inside the vascular system using catheter. What is digital subtraction atau substraksi digital? Itu penggunaan komputer, the usage of digital systems to erase, untuk menghilangkan gambaran tulang. Gunanya untuk apa? Memperjelas gambaran pembuluh darah. Why we do that is to clearly visualize the vascular system. Jadi apa itu cerebral DSA atau DSA otak atau digital substract angiografi otak? Itu teknik pencitraan yang menggunakan media kontras, sinar X dan sistem digital canggih untuk visualisasi pembuluh darah otak. Jadi what is cerebral DSA? It's an imaging technique that uses contrast media, X-ray and sophisticated digital systems to visualize the inside of brain vascular system. History, kita akan berbicara mengenai sejarah terlebih dahulu. Angiogram yang paling pertama itu dikerjakan hanya beberapa bulan setelah ronsen pertama dibuat. Jadi tahun 1896, so the first angiogram is performed at a cadaver several months after the first ronsen image is made. It uses the mercury salts, menggunakan garam merkuri yang dimasukkan ke dalam kadaver that is injected inside the cadaver. Here we can clearly see the image of the vascular system. Di sini kita bisa melihat dengan jelas adanya kemampuan untuk visualisasi bagian dalam dari pembuluh darah. Mulai tahun 1930 mulai ada angiografi itu, and in 1953 Seldinger introduces the method of vascular catheterization. Pada awal tahun 1960, Mason Jones itu memprakarsai penggunaan transbrachial. Jadi awalnya they use brachial artery to go to the coronary angiography. But at the late of the same year, they already developed transfemoral angiography, di mana menggunakan titik masuknya adalah pembuluh darah besar yang ada di pelipatan paha atau femoral access. Sejak saat itu akses femoral menjadi yang paling sering digunakan. Ever since then the femoral access is becoming the mostly used in angiography techniques. Contrast media kontras itu they are usually iodine based, berbahan dasar iodium yang memiliki sensasi hangat saat disuntikkan. That sometimes people will feel warmth during injection. And in some very sensitive individual, they can taste, mereka bisa merasakan rasa seperti betadine. Here we have a iodium-based antiseptic, povidone iodine. People here know the name of betadine. So especially when we perform the DSA, when we inject the contrast in the common carotid artery or at the external carotid artery, because there are arteries that go to the lingual artery, and sometimes they will feel, they can taste the povidone iodine. Kadang-kadang karena zat kontras yang dimasukkan itu kadang-kadang, terutama kalau kita menggunakan menyuntikkan kontras tersebut ke ada pembuluh darah di sini yang maju ke lidah, dan jadi kita bisa merasakan rasa seperti iodium itu tadi, seperti betadine. Ekskresi utamanya melalui ginjal. The primary excretion of the contrast media that is iodine based is from the kidney. That is why we have to have a baseline of renal function if we want to perform angiography. Jadi maka dari itu kita perlu dasar pemeriksaan laboratorium salah satunya adalah pemeriksaan fungsi ginjal untuk mengetahui apakah pasien ini aman untuk dilakukan penyuntikan media kontras. Pada individu tertentu bisa didapatkan ada reaksi alergi, mulai yang berat seperti anafilaktik, atau yang ringan seperti gatal atau urtikaria. There can also be a potential for allergic reaction from the mild ones like itchy and urticaria, but also can lead to anaphylactic in some patients. We will discuss now about the indication and contraindication. Kita akan bahas mengenai indikasi dan kontraindikasi. Mengapa kita melakukan indikasinya dilaksanakan DSA utama adalah untuk lokalisasi dan evaluasi abnormalitas pembuluh darah. Seperti yang kita tahu ketika pembuluh darah, terutama yang di dalam otak, kita tidak bisa, dari luar kan tidak kelihatan. Nah, kita bisa melihat dengan melaksanakan DSA ini tadi. Anatomi vaskular pembuluh darah, anatomi vaskular organ tubuh seperti liver, GI tract, dan otak. Jadi kita juga bisa, we can also visualize the vascular anatomy for other organs such as the liver, GI tract, and the brain. There are currently no absolute contraindications, saat ini tidak ada kontraindikasi yang absolut, namun harus waspada sekali terutama jika ada riwayat alergi terhadap media kontras. Even the history of prior allergy to contrast media is if the patient needs, jika pasiennya membutuhkan, if the patient needs to be endovascular treatment, endovascular therapy, then we could use maybe lower dose. Bahkan pada penurunan fungsi ginjal itu juga kontraindikasinya masih bukan mutlak karena biasanya yang penting ada suatu koordinasi dengan mungkin dari bagian penyakit dalam. We can have a consultation from internal medicine such as in nephrology to sometimes there are patients that require hemodialysis after the injection of contrast media. And another kontraindikasi lainnya adalah abnormalitas faal hemostasis. If there is a hemostatic, there is a such as the decrease in thrombocyte, the increase of bleeding time or clotting time, maybe we would be more careful. But because the access is very small, then this is a bit safer than if open surgery is done. Kita akan membahas ini diagramnya, skemanya, apa sih itu DSA. Pasiennya itu tidur lalu dimasukkan ke dalam suatu alat yang mana alatnya itu menghasilkan sinar X dari bawah, menembus tubuh pasien, lalu ditangkap di detektornya. The patient will lie in a position and then C-arm will create X-ray and then it passes through the body and then collected by the detector. And this is where the digital subtraction angiography is different from regular or non-subtracted angiography. Di sini bedanya ketika kita menggunakan teknik angiografi dengan substansi digital adalah sinar X yang dihasilkan melalui tubuh pasien lalu ditangkap, lalu direkam dan oleh komputer akan dihilangkan gambar tulangnya. The bone is removed so that we can visualize the arteries better. Dari situ bisa keluar dari monitornya yang di depan operator maupun kita bisa print gambarnya. From there we can view the live images in the monitor or we can also print the images that is created. Akses yang seperti yang tadi sempat saya jabarkan di depan, akses terutama adalah menggunakan akses femoral atau melalui pelipatan paha. Di sini ada pembuluh darah besar, common femoral artery yang nanti pembuluh darah ini yang akan menjadi akses masuk. Akses masuknya itu kecil sekali, mungkin kurang lebih 5 mm, half a centimeter, itu nanti dipergunakan untuk memasukkan kateter untuk naik ke atas ke organ yang dibutuhkan. The access is used to insert the catheter and the catheter will go to the necessary organs. This is the cell decoder technique that I alluded earlier. Teknik ini adalah teknik untuk memasukkan kateter ke dalam pembuluh darah. Yang dituju adalah pembuluh darah femoral artery ini tadi. This is the artery that is used. Ini adalah penampakan bentuknya yang dimasukkan ke dalam. Jadi anunya kecil sekali. Luka yang dihasilkan adalah kecil sekali. That is why this is called the minimally invasive procedures, because they only make very small incisions, only about 5 millimeters, to insert this catheter inside the body. This is the types of catheter. Ini adalah jenis-jenis kateter yang tadi yang saya maksudkan, yang masuk ke dalam organ yang kita tuju. Macam-macam ini tergantung dari organ yang akan dituju dan tingkat kesulitannya. Ini adalah contoh ketika kateter itu tadi sudah masuk ke dalam pembuluh darah besar dan dilakukan X-ray. This is an example when we are performing an angiogram when the catheter is put inside the large vessel. Alasan kenapa saya menjabarkan mengenai teknik DSA adalah salah satunya tadi yang seperti saya bilang kan menjembatani knowledge gap, beda persepsi, karena seringkali terutama pasien jika tahu keluarganya ada yang mengalami stroke atau apa, kadang-kadang kan bertanya sakitnya keluarga saya ini apa, lalu kalau kita menjelaskan dan tidak kita jelaskan terlalu detail mengenai tekniknya, mungkin pasien akan bertanya-tanya atau keluarga bertanya-tanya tahu dari mana memang benar ada pembuluh darah yang pecah atau yang terutama kalau ada aneurisme yang belum rupture, unruptured aneurysm, sometimes we have to explain to the family or to the patient that they have an unruptured aneurysm, and sometimes the patient will ask, how do you know that I have unruptured aneurysms? That is why I try to make this presentation to be a bridge so that the patient or the family of the patient will have a little bit of understanding about what we do in interventional radiology to make a suitable image to present to the patient or patient's family so that they can know that, oh, my family or me or I am indeed having an aneurysm, an unruptured, because sometimes it is asymptomatic, especially when asymptomatic aneurysms. Okay, next slide. Okay, next slide. Okay, next slide. Okay, next slide. Next. Okay, next. Okay. This is okay. Back. This is an image of the non-subtracted carotid angiogram. We can see already the the internal carotid artery branches, kita bisa melihat cabang-cabang dari arteri karotid internal, tapi kita masih bisa melihat adanya ini tengkoraknya. Akan lebih jelas jika kita digitally subtracted, kita menghilangkan gambar tengkoraknya karena supaya bisa mendapatkan gambar yang lebih detail. Teknik ini tidak hanya digunakan pada otak saja, tapi juga bisa pada bagian lain dari pembuluh dari tubuh yang memiliki pembuluh darah, seperti contohnya ini namanya celiac trunk, ini adalah trunkus celiacus, itu tempat pembuluh darah utama yang keluar untuk memberikan makan ke liver, ke limpa. Kalau di sini kita bisa lihat, we can see that the presence of bones can sometimes distract us from the if there is a subtle abnormality. This procedure can also be used in other parts like in the extremities. Kita bisa juga menggunakan teknik yang sama contohnya di kaki. Di sini tulang pahanya masih terlihat, tapi dengan secara digital dihilangkan, jadi hanya kita bisa fokus ke pembuluh darahnya saja. So we can focus only to the vascular side. As you can see, this is the foot. So we have a motto in interventional radiology, we can visualize from head to toe because we can see, kita bisa melihat pembuluh darah mulai dari ujung kepala sampai ujung kaki. Khusus untuk diskusi kita hari ini, peran DSA pada tumor intrakranial, the role of DSA in intracranial tumors, this is a golden standard. Ini adalah golden standard untuk evaluasi pembuluh darah otak. Artinya meskipun ada pemeriksaan lain yang juga mampu visualisasi atau mengevaluasi pembuluh darah otak, namun sesekali ada keterbatasan. Seperti contohnya ada orang-orang yang memiliki alat pacu jantung, itu tidak semua yang memasang alat pacu jantung itu bisa dikerjakan MRI misalkan. Karena MRI kan bisa menggunakan, bisa evaluasi pembuluh darah otak, tapi tidak perlu menggunakan obat kontras. Tapi sayangnya tidak semua orang yang memiliki alat pacu jantung itu boleh masuk ke MRI suite. Jadi sometimes there is in other non-invasive evaluation for the cerebrovascular such as MRA, magnetic resonance angiography. Sometimes we cannot do that for patients with cardiac pacemakers. Not all cardiac pacemakers are prohibited. Sometimes there are, especially the newer ones, the sophisticated ones, we can tune the pacemaker so that it would be safe to enter the MRI suite, and then after the patient is done with the examination, the pacemaker is recalibrated so that they can use it, but not everyone will use that type of pacemakers. Evaluasi tumor-tumor yang berasal dari vaskuler, karena tumor itu kan artinya benjolan. Tidak semua benjolan itu, kadang-kadang ada benjolan yang asalnya dari pembuluh darah, contohnya AVM, ya, seperti itu kan membutuhkan DSA untuk evaluasi sebagai golden standarnya. Sometimes tumors that arise from vascular, we need evaluation for the DSA, especially for the feeding artery and draining veins. Untuk evaluasi ada tidaknya kelainan pembuluh darah yang menyertai tumor, karena tumor sesekali tumornya ada, tapi juga dia menyebabkan atau berada di dekat dari kelainan pembuluh darah, yang hal ini jika diketahui sebelumnya tindakan itu bisa membantu persiapan dan tindakan operasi. Evaluasi feeding artery dan draining vein, untuk misalkan suatu tumor itu terkadang diperlukan evaluasi pembuluh darah mana yang memberikan makan dan mana pembuluh darah yang nanti dia keluar ke pembuluh darah baliknya. Dari DSA itu terkadang kita bisa memberikan informasi mengenai hal tersebut. Evaluasi ada tidaknya variasi anatomi pembuluh darah, karena tidak setiap orang kan sama, kadang-kadang ada variasi yang jika diketahui sebelumnya akan sangat membantu pada tata laksana tumor. Terima kasih. Thank you. Jawab sekarang atau nanti?
Our questions will be discussed about all of the presentation done. So maybe after this, I would like to invite Dr. Bayu also to tell about his case, his special case, maybe when he's practicing in National Hospital. So, but before that, I want to apologize about technical issue that we have to experience just before when Dr. Ue-Cheung doing the presentation and Dr. Bayu doing the presentation. But thankfully that all of us can listen to our speakers still better because this is presentation really wonderful today. So for Dr. Bayu, please tell me about your case.
Mohon maaf karena hari ini target audiensnya adalah ada awamnya, jadi kami kebetulan kami tidak menyiapkan kasus, tapi melainkan untuk itu tadi presentasi untuk memberikan gambaran. Izin, Dr. Irwan.
Thank you, Dr. Bayu. And for our last speaker, we already here with us Dr. Irwan Barlian Immadoel, specialist Bersama consultant oncologic, will be presented about comprehensive brain tumor management in National Hospital. For Dr. Irwan Barlian, please welcome for your presentation today.
Good evening. Assalamualaikum warahmatullahi wabarakatuh. I'm so sorry because I'm a little bit late because I just finished my case today. So welcome to our guests from Taiwan, all of you. Hope you enjoy in Surabaya. I will start my presentation. We start to build our new comprehensive for brain tumor, but yeah, but now it's still unestablished, so we're still building a new center for this hospital. So, but I will share our case. As we know that the case of brain tumor is so many, you know, especially in Indonesia. Benign tumor is more common than the malignant tumor, especially for meningioma. We don't know, sometimes the case or the epidemiology is a little bit different with other country. Maybe because of this, in our country we use massive hormonal contraception for birth control, so it's still on research, but we cannot make any suggestion about the oral contraception for birth control. Sorry. Back slide. This is in the last 10 years, this is our cases. Most of the cases was a benign tumor, and malignant is almost a quarter from the benign. Next case. In the last 10 years, we operate about 1,540 cases, and most of the cases was meningioma. It's about 41%, and others tumor. Next slide. In this, our hospital, in National Hospital, we still start to build our new center of excellence for the brain tumor. So our priority now is for awake surgery, our complex tumor for skull-based tumor, and endoscopic surgery for pituitary or skull-based tumor. So that's our, we operate most of the cases, but now that 3 point of cases was our priority. That's why we start to build a comprehensive brain tumor services. First, we also collaborate with other physicians like neuroanesthesia, neuroendocrine, neurorehabilitation, and hemato-oncologists, neuroradiologists, and our team, cardiologists and nutrition. So I hope the case, our patient will be treated by many doctors in this hospital, not by only a neurosurgeon, but also before the operation we discuss with the neurologists and other team. Besides the human resources, we also have quite good facility, like a rehabilitation center. I think it's now we have a new equipment, so it's very important. Intraoperative monitoring center for surgery. We also need. We also have a cath lab, EEG, neurointensive care, endoscopic tools, and neuroimaging. I will show some cases that we treat already. This, for example, a 37 years female with a decrease of consciousness for 2 days, and unfortunately this patient was pregnancy. So they come with unconsciousness. She come with, and we found some tumor in the foramen magnum. Slide. This is the tumor, and the tumor is quite big and compress medulla oblongata severely. So this is, and it's quite a solid tumor. So we start to operate with far lateral approaches. So this is one of a case of pregnancy in meningioma. So we have some cases with the pregnancy. Usually come with the decrease of consciousness. We still make some journal for that, so I hope will be submitted soon. So this is one of the cases. Usually the case with convexity meningioma, most of the cases, but these cases come with foramen magnum meningioma. So we also collaborate with the obstetrician to terminate the patient before terminate the child before the surgery. So we can remove this tumor completely, and this is the CT scan post operation. It's look like quite good. And another case with this is skull-based cases with petrocleval meningioma. We also operate these cases with combined petrosal approach. This slide. Of course, we did angiography to study the vascularization. This is our approach. This is basically a modified combined petrosal approach, not usually petrosal approach by other surgeon, because this time we didn't cut any petros apex. We only cut the petros bone, and then we cut the tentorium. So this is, we cut the tentorium. So basically this is a modified transpetrosal approach with transtentorial approach. So we cut the tentorium quite big, and then we can have a good view from that cutting of the tentorium. So this one of the case of the skull-base tumor. So also we can remove total of the tumor. This is quite good. And then we also operate endoscopic surgery. Most of the cases was pituitary adenoma, but now we start to develop to other cases like a meningioma or chordoma. It's like this is for endoscopic for pituitary. Next cases. Next. And we start the meningioma cases. We start with the small one. So endoscopic transpenoidal approach. So right now we still start the meningioma for endoscopic approach. Now we still doing like it's about 20 cases until now. So still, I still learning the techniques. It's quite difficult. And then we also start the glioma surgery for awake surgery since 2017. We are now operate about maybe 50 cases with awake surgery. For example, these cases with recidive cases with glioblastoma in broca area. So we operate with awake surgery. We use a navigation and of course intraoperative monitoring. So this case with we always join intraoperative monitoring with a neurologist and also neurophysiologist. So I operate this case about 3 years ago with pathology was GBM. Now the patient still in outpatient clinic and is doing great, good. No aphasia post-operatively. Another case with insular glioma. We also operate with the case awake surgery. So we still develop for many cases, but yeah, we have limitation with the facility and also other teams. So we try so. So this case also operate 1 year ago. So the patient still also with a good condition now, still on outpatient clinic. So this is our some cases that I would like to show you, and then our hope for the future that we can make a good and strong center of excellence for brain tumor in this hospital. Maybe intraoperative MRI. Or and also maybe radiotherapy because it's very important if we build the brain tumor center, we should have radiotherapy or maybe gamma knife. Okay, I think that's enough. Thank you very much.
Thank you, Dr. Irwan Barlian, for the amazing presentation and case sharing for us today. First of all, I want to greet our CEO of National Hospital, Mr. Ue-Cheung Ho, who already joined us today. Good afternoon, sir. Mr. Ue-Cheung, our CEO. Okay, and we already listened all of our speakers and with their presentation, and now I open to Q&A. So who wants to ask questions to doctor could stand up, and I will tell your name and your questions. So maybe before Dr. Irwan, there is a questions for Dr. Bayu from. Your question to Dr. Bayu? Dr. Bayu, please welcome.
The last
Okay, so
presentation that you gave,
Yes.
I just want to ask how
Yes.
long it normally takes to be cured, this kind treatment.
the time for the procedure done.
Yeah.
So the average time for
Basically.
average time for the digital subtraction angiography procedure.
PSA, yes.
Okay, if uncomplicated, between 30 minutes to 1 hour, we already can, from the time from the time of puncture to the pull out of all the catheter, we usually only take 30 minutes. Tanpa komplikasi, mulai dari masuknya jarum sampai pull out alat, sampai semua alat keluar dari pembuluh darah, kurang lebih 30 menit kalau untuk diagnostik, untuk pemeriksaan diagnostik DSA.
So we have in advance how long it takes for the
Yes.
appointment before the operations.
Oh, oke. Tapi jadi for this procedure untuk pemeriksaan DSA, karena menggunakan zat kontras yang dimasukkan ke dalam arteri, sebaiknya ada puasa. Gunanya supaya perut dalam kondisi kosong. Karena seperti yang saya bilang, salah satunya kan ketika zat kontras itu dimasukkan ada rasa seperti betadin. 1-2 orang tidak tahan lalu dia mual atau muntah. Kalau lambungnya masih terisi penuh, itu khawatirnya pada saat tindakan ada muntah kan akan lebih susah karena dilaksanakan di ruangan yang steril. Jadi sebaiknya ada puasa 6 jam sebelumnya. Lalu we usually tell the patient to fast 6 hours prior to procedure, just so that we can make sure that there are no food or liquid inside the stomach, so to prevent any such as vomiting or nauseous. And after the procedure, setelah tindakan cabut alat itu kita akan melaksanakan namanya kompresi. We will perform a compression at the puncture site. The compression we compress for about 30 minutes. Kita tekan selama 30 menit. Lalu karena ini kan pembuluh darah besar yang kita lobangi, itu kita memberikan waktu supaya aman, tidak terjadi berdarah, tidak terjadi bocor, begitu prinsipnya istilahnya. Kalau tanpa menggunakan vascular closure device, kita memberikan waktu biasanya 8 jam, baru pasiennya boleh ambulasi, baru boleh jalan, baru boleh mulai berdiri. Kita kasih minimal 8 jam. Kalau kita tidak menggunakan alat untuk menjahit tadi si pembuluh darah, kita biasanya pasien kita sarankan untuk nginep dulu ya, 1 hari, besoknya baru bisa pulang. Seperti itu. Kalau menggunakan vascular closure device, kalau menggunakan alat untuk menjahit pembuluh darah itu tadi, bisa lebih cepat. Namun Jika dalam waktu dekat diperlukan tindakan lagi, itu kita harus pindah ke seberangnya. Jadi saya lebih suka menggunakan teknik kompresi karena dia tidak perlu waktu tunggu jika besok hari ternyata dibutuhkan tindakan lagi untuk akses vaskular, kita bisa melaksanakan. Kurang lebihnya. I try not to use vascular closure device because if we use a vascular closure device, we cannot perform a puncture in that exact site for approximately 30 days because we need we have to change site. That is why I do not like to use vascular closure device because if we need to perform another endovascular intervention, such as if we find an aneurysm and we need to clip it, we need to use coil, then we cannot use the same vascular. That is why I like to use compression because without vascular closure device, we can use the same artery to puncture.
All right. Thanks for the explanations.
Thank you, Dr. Bayu. So, if there is another questions for our doctors here, yes, doctor.
Okay, thank you very much. I'm Ahmad Fahmi, I'm neurosurgeon. My focus in Parkinson and movement disorder actually. I have 3 questions, one for Dr. Chung. What do you think was a treatment for wet neck aneurysm? What do you prefer? You use flow diverter or stent assisted coiling? Yeah. Usually in our country there is many rupture in here. Yeah, we limited number for non-rupture aneurysma. Usually the patient come to us already rupture, and sometimes we doing the coiling and EVD and lumbal drain. Sometimes we doing stent assisted coiling, and sometimes we doing the flow diverter like that. For wet neck aneurysm, what do you prefer in your center? Flow diverter or stent assisted coiling? And the second question for Dr. Bayu, thank you for nice presentation. When the fastest time to do the surgery if we do the digital subtraction angiography? I mean, after DSA, how many surgery? What do you think the biggest challenge to do that? Okay, thank you. Thank you very much.
Thank you, doctor. And for the first answer will be answered by Dr. Ue-Cheung.
Okay, thanks for your question. To be honest, most of cases of endovascular intervention are treated by our radiologists. So I'm not so familiar with this kind of procedure, but we have some conference and case sharing with the radiologists and the neurosurgeon. So maybe I can try to explain our hospital's policy to treat this kind of aneurysm. If the base of aneurysm is wide, then you may know that the simple coil is not enough because the coil may be going to the perineal artery. So the stent assisting coiling is suitable for these cases. But what if there is other branches of perforating artery? It's just near the base of the aneurysm. If we will use the stent-assisted coiling to this kind of region, then there is risk of the sacrifice of the penetrating artery, especially in the paracardial artery, because there are anterior colloidal artery and a posterior communicating artery that we cannot sacrifice, and especially if the patient had a fetal type PCOM or PCA. So in such kind of the patient, the radiologist may perform flow diverter to this patient. Because the flow diverter is quite different from the stent, because this mesh is quite small, so it uses the flow dynamic change to cause the aneurysm thrombosis spontaneously. And it also had the risk of the compromised blood flow into the perforating artery. But as the experience from our radiologists, and the risk is not quite high. So we will use this kind of flow diverter to treat this region of aneurysm. And it's also a complicated because if the patient have to use the stent acetylcholine or the flow diverter, they have to administer anticoagulant. It may complicate the following treatment course if the patient had other surgery like hydrocephalus or other intracranial results. It may complicate the treatment course of this kind of disease. So it just depends. We have to have a comprehensive discussion with the radiologist. Sometimes we postpone the treatment and just do the emergent surgery, then arrange another time to let the radiologist to perform the intervention. Yes.
Once again, continue to the question. How about the lumbal drain and extraventricular drainage? What do you prefer? I looked at you do the lumbal drain, yeah? Lumbal drains of lumbal and extraventricular drainage, EVD. What do you prefer for that? Thank you.
Okay, if the patient had obstructive hydrocephalus at the initial arrival, then we definitely will do the EVD to do the CSF diversion. And we insert lumbar drain just for the better CSF flow, but we will do the CT scan at a 4 days after the operation. If there is also a sign of obstructive hydrocephalus, we will not do the lumbar drain because it has the risk of downward herniation. If the conditions allow us to do the lumbar drain, then we will insert the lumbar drain and bridge EVD to 2 days. Then we insert the lumbar drain and drainage about 30 milliliters every 8 hours. It depends. Every attending's philosophy is not equal. Maybe some attending want to drain more, maybe 40 or 50 milliliter, and maybe they will drain every 8 hours or 6 hours. It's also different in the literature review, so it just depends on the attending's thinking. And after we insert the lumbar drain, we will clamp the EVD and just use the EVD to monitor the intracranial pressure. It's very interesting because if we use only the EVD to examine or to monitor the intracranial pressure, and the patient may have increasing intracranial pressure during their course. But if we insert the lumbar drain, then the intracranial pressure will decrease very rapidly. But I don't know what is the pathophysiology inside. So maybe if the daily drainage of the CSF from the EVD is large, about maybe 100 or 200 milliliter per day. If I set the pressure threshold above 50 millimeter mercury, or maybe 10, it just depends. And maybe we will think that it is impossible to remove the EVD, right? Maybe the patient needs a permanent shunt placement. But if we use a lumbar drain at this kind of patient, and we only drain maybe 20 or 30 milliliter every 8 hours, so the daily drainage amount is below 100, right? But if we do this kind of procedure, then it's a very interesting phenomenon that the intracranial pressure detected by the EVD will decrease rapidly. So this kind of patient can safely bridge to this intervention. But maybe this kind of patient still had the need for permanent shunt, but that's just wait and see.
Thank you, Dr. Ue-Cheung. And we're going to the second. Dr. Bayu, please.
Waktu untuk melaksanakan tindakan operasi setelah tindakan DSA diagnostik. The time interval after the initial diagnostic DSA, cerebral DSA, to the operating table. because we use heparin, yes, because we use heparin approximately 3,000 to 5,000 units in 500 cc's, it would be safer if the patient can be prepped for operation the next day. Because the half-life of heparin, if I'm not mistaken, about 90 minutes. So, but we will wait for the next day because of we are uncertain, tergantung dari berapa lama tindakan DSA-nya, depending from how long the procedure takes for the diagnostic DSA, because the heparin and solution will go continuously, karena dia akan continue supaya tidak ada trombus. Itu semakin panjang waktu yang diperlukan, berarti kan semakin banyak heparin yang masuk, jadi tetap aman untuk keesokan harinya. Namun jika memang sangat diperlukan sekali untuk tindakan dilaksanakan keesokan harinya, bisa dikomunikasikan, nanti bisa kita persiapkan untuk tindakannya tidak menggunakan heparin, namun tentu saja akan lebih aman jika menggunakan heparin. We usually wait for 24 hours to be safe. Thank you.
Thank you, Dr. Bayu. And for the last question will be answered by Dr. Barlian.
Thank you, Dr. Fahmi. Dr. Fahmi is my senior, so he always give me difficult question. So I don't know how to answer it. So of course we start the WEG surgery with big mortality. Big morbidity. That is, I always remember that is our first cases that we operate with WEG surgery. That time because I just finished my study and we discussed with other team, anesthesiologists, neurologists, and of course they are more older than me. So I always say yes, yes, yes. Unfortunately, during that discussion, of course, during the discussion and the operation is totally different. So that is our first case is totally failed. The patient got hemiplegic during the operation. So that's we start, and then after that we stop the WEG surgery and we learn more. It's about maybe we stop for it's about 1 year. So we learn more and then we start again with a new team, with a young doctor, so we can discuss more open. So it's the hierarchy in medical. So the most difficult is to make a good team with the neurologists, the anesthesiologists and other team. But for me, as a neurosurgeon, of course, the most difficult for the cases is how to stop the surgery, how to stop, when to stop. Because the goal of the awake surgery is safe maximal resection. So if we want to make a radical resection, no need awake. So just remove the tumor. But with awake surgery, so it's of course difficult because we need to stop before something happen. So that sometimes the make a very difficult decision during the operation, the operating theater. So I think that's the most difficult is to know when to stop the surgery. Thank you.
Thank you, Dr. Barlian, for the answer, and that will be the last question for today. And I would like to thank you for all the speakers and all of our guests who was come far away from from the National Taiwan University Hospital Union Branch for coming to our hospital, National Hospital. So maybe that's all for us. Thank you for joining us, for all the participants, the media, and for the audience. So maybe we will see you in another case sharing and discussions. Thank you and good afternoon for all of us.